Okay then. So, Assalamu alaikum everyone. Good afternoon again. I'm glad to see you back or hear you back again. Inshallah, today we will continue where we stopped last time. So, we will not be repeating what we discussed about the routine testing and the mixing. However, mixing may be relevant. So, if you have any questions, I will give you a small break where we will do that before we speak about the factors because that's where the relevance comes. So if you have any questions about the mixing, anything that is not very clear, that would be a good time to ask. So last time we stopped at routine and mixing, as I said. Today we will continue with D-dimer. So we finished this part. Now we have D-dimer today. Then we'll speak about fibrinogen degradation of products. Then we will continue this section because we did not finish all of it. Then we'll speak about factor deficiencies versus factor inhibitors. And finally, we will finish with the thrombophilia. Now, I'm not so sure that we will get enough time to finish all of them adequately because I don't want to rush through slides just to finish them. That's not the goal. The goal is to give you information as clearly and as adequately as possible. So I will not extend more than 2 hours unless you agree. Otherwise, we can continue with another session later on. So, Bismillah. So D-dimer. I want to get very technical, but there are some very important points that I thought would be worth highlighting. So for a start, what exactly is D-dimer? I'm sure most of you are quite familiar with it, but it's good to go over the basics. Now, whenever a clot starts to form in vivo, we naturally start with fibrinogen that is then turned into fibrin. And as you know, fibrin monomers or fibrin molecules will stick together, making polymers that basically glues the clot together because you know the clot is formed from RBCs, platelets. Fibrin just makes it stick together better. Now, at this point, as you see, we have DED. Every fibrin monomer, every fibrin molecule is formed from a D subunit, E subunit, and another D subunit. They stick to each other using hydrogen bonds, etc., etc., etc. At one stage, factor 13 comes and links D and D together, as you can see in this red box. D and D together are linked by factor 13 using covalent bonds, which are quite strong. So we have something here that looks like this. So D and D from two different fibrin monomers are linked together. Now we have a stable clot. At some point, this clot will no longer be useful because, okay, I had a trauma, I had a cut, I had some issue with the blood vessel, it's bleeding. So I need to stop the bleeding. So the clot forms, then we repair the tissue, then at some point the clot is no longer needed. At this point, we need to start breaking the clot because if it stays there, it will cause problems. This is where the process of fibrinolysis comes from. So we are lysing the fibrins. We are breaking the fibrins or the fibrin clot more specifically. Now, the protein that does the fibrinolysis or that breaks the fibrins is called plasmin. It's the main actor in the process of fibrinolysis. Plasmin can cut in many locations within the fibrin molecule. It can cut between the E and the D. However, one very important distinction. Plasmin cannot cut the covalent bond that factor 13 formed between D and D. So after plasmin does its work on fibrin, D and D molecules are seen in the blood. And these D and D, because they are two Ds, we call them D-dimer, two molecules of the subunit D. So that's where D-dimer comes from. So very simply, D-dimer, when it's present in the blood, it indicates that at some point, a clot has formed in the blood, okay? So D-dimer is an indicator that clotting has formed. So D-dimer is called a fibrin degradation product because without a clot, you do not have fibrin. Okay? So D-dimer is a very important marker of clotting and fibrin degradation processes. The fibrin degradation process is simply fibrinolysis. Okay? Now, what is really the importance of D-dimer? Why do we care? Okay, because, okay, it tells us that there is a clot. Then what? Does that mean we can use it to diagnose all kinds of clots that arise? No, no, that's not how it works. Everyone would hope that this is how it works, but unfortunately it doesn't. D-dimer use is very, very specific. we usually rely on a cutoff. I'm sure you have seen before that D-dimer, if it's higher than, let's say, 0.5 or higher than 500 nanograms, or if it's higher than a specific number, we say that D-dimer is positive. If D-dimer is less than this number, this cutoff, we say D-dimer is negative. Okay, so then how do we use it? What does it tell us? When D-dimer is positive, this just tells you one simple thing, that there was a clot. What is the nature of the clot? What disease is causing this clot? We have no idea. Okay, we have to diagnose it using other means, because D-dimer just tells you there's a clot. It doesn't tell you the reason behind the clot. It doesn't tell you the diagnosis of the patient, just that there's a clot. However, D-dimer was validated for the very specific following use. When D-dimer is negative, in certain circumstances, we can say that the patient is not having PE or DVT. PE is pulmonary embolism. DVT is deep vein thrombosis. So these are two pathologies that are caused by a clot in the blood vessels. Normally, we do not want clots in the blood vessels if there is no bleeding, if there is no cause for a clot, okay? Because that means that we might block the blood vessel. What's behind that point might start to die because of the lack of a blood supply. So PE and DVT are clots that form in the blood vessels where they should not be, okay? So if D-dimer is negative, this means there is no significant clotting in the blood, because again, remember, D-dimer is just a sign of clotting. However, if D-dimer is positive, we just say there's a clot. We don't know what's the reason behind the clot. We have to diagnose the patient using other means like imaging, ultrasound, CT scans, and all of these things. Okay, so this is a very, very important point about D-dimer. If it's negative, we can only say the following, that it excludes PE and DVT under very specific circumstances. I will explain in the coming slides. When it's positive, we don't know. We have to go through other diagnostic steps, which are more specific than D-dimer. Now, this line is important. D-dimer has very high sensitivity and negative predictive value. What this simply means, sensitivity means that even if there are very tiny amounts that are present, the assay is very good at detecting D-dimer. That is, the assay does not miss any D-dimer that's present in the sample, because if we miss D-dimer, maybe the patient has clotting at some stage, but we missed it, and the patient will have a false negative test. So maybe, for example, we will discharge the patient thinking they are normal where they are not, which is not good. Negative predictive value means that if the D-dimer is negative, that the patient does not have that specific disease we are looking for. So negative predictive value has to do with the presence of disease. Sensitivity has to do with the presence of the thing we are measuring, which is D-dimer. I will not detail much on this point, okay? It doesn't matter all that much to us. So, as I just explained in the previous slide, I can only say that the patient does not have PE or DVT under specific circumstances. So what are these circumstances? Now, if you look at this graph, we'll take it one step at a time. So we say suspected VTE. What is VTE? VTE is venous thromboembolism. Venous thromboembolism means PE or DVT. So PE or DVT, they are two different pathologies, but we will put them under one umbrella called venous thromboembolism. Okay, so whenever you see VTE, we're referring to PE and DVT. So the patient walks into the emergency room, for example. The doctor is suspecting that this patient might have VTE because they have certain clinical symptoms. So the first thing, do I run D-dimer? No. We do something called the pretest probability of VTE, this pretest probability testing. So what happens at this stage? We look at the patient. Do you have symptom X? Do you have symptom Y? We run a few routine tests like fibrinogen, like CBC. How much are your platelets? How much is the level of fibrinogen in your blood? Then, based on these items, there's a checklist that, do you have this? No. Do you have this? Yes. Do you have that? Yes. You will end up with a score. If the score is this, you have a low pretest probability. If the score is that, let's say if the score is below 2, we say you have no pretest probability, for example. If the result is, let's say, 2 to 5, you have a moderate probability. If the test result is, let's say, more than 5, we say you have high pretest probability. What that simply means, if you have a higher probability, you have a very high likelihood of having VTE. Moderate probability means you have a moderate probability of having VTE. Low probability means you have a slim chance of having VTE, so a few percent usually, okay? Now, D-dimer is not very useful when you have a high probability of VTE. These people with high probability of VTE, we directly go to imaging. We don't look at D-dimer because the chances of you having a VTE are very high. I will not wait for the D-dimer results, okay? Because your chances are already very high. I don't need a test to tell me to exclude or not exclude. I will run with the patient to the imaging, okay? Whatever is that imaging, that's not our topic. Imaging is the diagnostic test that tells me if the patient actually has VTE or does not have VTE. D-dimer does not tell me if the patient has VTE or not. D-dimer just says you have a clot. What is this clot? I have no clue. How about people who have low or moderate pretest probability? These are the ones where D-dimer is useful. So for these people, I run a D-dimer test. So I have two outcomes. The D-dimer either comes back negative, that is below the cutoff, or the D-dimer will come as positive, which is the D-dimer above the cutoff. So if the D-dimer is positive, above the cutoff, we say, okay, we will send you to imaging because we want to see what is this clot, what's causing this clot. I want to diagnose what's going on with this patient. And only imaging can do that for me. How about if D-dimer is negative? D-dimer is negative. Okay, the patient has no clinical symptoms. We have no reason to keep the patient in the hospital, for example. So we have no reason to suspect VTE. The patient may be discharged at this point, but of course, the doctor will not just look at D-dimer exclusively. There are clinical symptoms, maybe there's a history for the patient, but at this stage, if D-dimer is negative with low to moderate pretest probability, we can exclude PE or DVT. To discharge the patient or not, that is the clinician's decision. It's not the test. It's not based on D-dimer only. There are other criteria. So this is very important. So D-dimer value is only for low and moderate pretest probability. D-dimer is validated to exclude PE and DVT only for these people and only for outpatients. D-dimer is not used for inpatients because these people have high chances of developing clots and D-dimer is not validated for them. So D-dimer is useful to exclude PE and DVT for low or moderate pretest probability patients who are outpatients. This is very, very important to know. Now, away from the clinical scenario or what's going on with patients, we'll talk a little bit about the tests themselves. Before I continue with the tests, does anyone have any questions? Because it's very important to understand what I have just explained. Is everything clear about the D-dimer? Clinical aspect of it. Any questions?
No questions.
All right. I assume it's clear. Thank you. Thank you. Now, for D-dimer assays, you know there are so many D-dimer assays in the market. For example, if you look, these are just some of what's available in the market. Now, one issue that often arises in labs that are starting the validation of the assay, you receive a new analyzer, you start with a different company, you want to do comparison. So you start comparing D-dimer results. For you to find that the results between, let's say, Sysmex and Stago or Roche and Werfen are very, very different for D-dimer, which in this case probably will make you quite concerned. Why are my D-dimer results so different? This means that my comparison study failed. Now, one very important thing, D-dimer assays almost, I will not say almost, but generally, or the majority of times, do not really agree on the quantitative readings that you are given. What do I mean with that? For example, we have 5 samples in this study that were run on all these different kits. They are different kits from different manufacturers. If you look at the numerical values, for example, for sample 5, because these are the ones that show most discrepancies, do you see the values reported? They're quite significant. They are as high as 9,210 for one kit, and as low as, what is the lowest one? 485. So this is a huge difference in the quantitative results. You can see similar differences in other samples. So what does this mean? Does this mean all these kits are bad? Does this mean that these people don't know how to run the test? What's going on? Now, the point is a bit technical, I explained to you, but for you, the important point is we never compare the dimer results quantitatively. All right? Why is that? Can I not compare just two different kits? Because they should agree. I need to validate my analyzer. I need to validate my kit. This is not how it works for D-dimer. D-dimer kits, in the majority of cases, almost always agree on the result of the patient being negative, that is below the cutoff, or positive, that is above the cutoff. Again, the dimer assays generally agree very well on positivity or negativity of the result, not on the number. Why is that? Where did the slide go? Okay. Now what happens actually is D-dimer does not have an international standard like many assays. For example, factor assays, they have something called an international standard, okay? So almost all manufacturers, they use the same international standard. So when they produce calibrators, the results of the calibrators are very close. So if you run a factor assay on your analyzer, on Roche analyzer, on Sysmex analyzers, the results generally agree, quantitative results. However, for D-dimer, we don't have an international standard, which means every manufacturer of these and even more, every manufacturer has to produce its own internal calibrator. And this creates a lot of difference between manufacturers. Another point that adds to this discrepancy, we have 54 different antibodies which are used for D-dimer detection because the D-dimer assay is an antigenic assay. We use antibodies to detect D-dimer. So the use of different antibodies also contributes to this difference or discrepancy that you would observe between the results of different studies, of different kits, sorry. Okay. So what I'm trying to tell you here is you cannot really compare the dimer results between different kits because there is no international standard. So the standards are specific to each manufacturer, and this means they're quite different. And the other point is that we have so many different types of antibodies, and this is definitely something that will cause a difference in the results. However, again, remember, generally, these assays agree on negativity and positivity of the results based on the cutoff. All right? Now, this cutoff that I keep mentioning, what do I mean by that exactly? Again, it's a very simple concept. I'm sure you are very familiar with it since you are doing D-dimer testing on almost routine basis. Cutoff is simply the value that I say more than this value. If the D-dimer result is more than this value, the patient is D-dimer positive. So there's a clot likely somewhere. If the result is D-dimer negative, I can only say the following. PE or DVT are excluded in patients who are low to moderate pretest probability, who are outpatients. That's the only officially claim that any manufacturer in the market currently has for D-dimer. Can I exclude, for example, that the patient has a ischemic heart attack, that the patient has a stroke? I cannot exclude any of this. None of this is validated for D-dimer. Okay, so this is very, very important. Now, if you look here down, do you see it says this is only applicable to outpatients with moderate to low pretest probability for VTE or PE? This is what we are saying. There are some exclusions. So for pregnant women or people who are old, generally above 50 years old, there are specific situations. So for example, for pregnant women, usually with the second and third semester, D-dimer is no longer that useful for reasons that are beyond this discussion. For people who are above 50 years, we have an adjusted cutoff. We changed the cutoff using some calculation. And this is what some studies suggested. This is not the official claim from Istago, for example, but some studies are suggesting the use of an adjusted cutoff for people who are older than 50 years. But this is beyond the topic of this discussion. Okay, if you'd like to discover this a little bit more, we can discuss it at the end. So, where do I get this cutoff? CLSI tells you very clearly, as a lab, you can, if you choose, you can establish your cutoff, but this is very, very difficult. I'll explain. So CLSI says, because we know that this is very, very difficult for the lab to do, that is establish your own cutoff for D-dimer, because it's very difficult, you should ideally, as a lab, follow what the manufacturer is suggesting to you as a cutoff for the D-dimer. So every manufacturer who sells you a D-dimer kit will have a cutoff for their D-dimer assay. Why is it very difficult? Because when you want to establish a cutoff for D-dimer, you actually need to verify that when the D-dimer assay that you have is negative, this actually correlates with the patient not having PE or DVT. The way for you to do that is to do imaging studies and follow the patient for a few months to make sure that actually they did not develop PE or DVT. So this actually turns into a clinical study that is very complicated, very costly, and requires lots and lots of patients. For example, the cutoffs that are established by STAGO for their D-dimer assay used up to 4,000 patients across 25 different medical centers. And it took years. So you can imagine that this is not something that a lab can just do. Okay, then do I need to verify the D-dimer cutoff? No, you're not required to do that because, again, that will be a very, very complicated work to do. It's not easy for a lab. And again, it's very costly, very complicated, very lengthy. So usually CLSI says, because of all these considerations, just take the manufacturer cutoff, work with it as it is. You don't need to verify, you don't need to validate. Okay? As long as the manufacturer officially claims that their kit can exclude PE and DVT. So, any questions about D-dimer before I move on? I'm asking again because I know D-dimer is quite important and sometimes these things can be a bit confusing. So should I move on? D-dimer is good for everyone? I assume that's a yes then.
Move on.
All right, thank you. So moving on into fibrin-fibrinogen degradation products. Now, if you remember, I told you D-dimer is a fibrin degradation product. I cannot possibly have D-dimer as a fibrinogen degradation product because D-dimer is only formed when a clot forms, when factor 13 does its activity. So these conditions only exist when fibrin clot forms, okay? However, fibrinogen degradation, fibrinogen itself is not really linked by factor 13. So fibrinogen cannot really generate D-dimer. However, this assay says fibrinogen degradation products. So does it measure fibrin or does it measure fibrinogen degradation products? It actually measures both at the same time. So if we come back to this, we said when we form a clot, fibrinogen is turned into fibrin via the activity of thrombin, okay? Then fibrin monomers stick to each other spontaneously, as you can see. Then factor 13 links the D to the D, so we have the covalent bond, so this forms a D-dimer. So this is what you would normally expect in a normal clot. So this, after it's being broken by plasmin, forms fibrin degradation products, okay? D-dimer is one of these fibrin degradation products because fibrin degradation products include the E domain, the D domain, different forms of each, plus the D-dimer. So D-dimer is just one of the fibrin degradation products. However, and this is more commonly happening in the case of something called DIC, disseminated intravascular coagulation, DIC. Disseminated means something that is spread over or something that's systematically happening or widespread. Intravascular, because it happens within the blood vessels generally. Coagulation is coagulation, a clot is forming. So disseminated intravascular coagulation is a pathological state where your body starts to form clots basically all over, which is definitely not a normal scenario. You don't want your blood to start to clot all over, because if your blood clots all over, then definitely at some point that will cause you a lot of problems. Actually, DIC can develop so badly and so rapidly that a lot of people die because of DIC. So what does really happen in the case of DIC? Generally, this starts with cases such as, for example, sepsis. Sepsis can trigger DIC. What happens in the case of sepsis, I will not go through all the details. At some point, clotting is activated all throughout your blood, all throughout the circulation. So this means you have too much coagulation happening at the same time. So you have excessive generation of thrombin because coagulation is being activated all over the place. The coagulation cascade is being activated at a very large scale. So I'm forming so much thrombin. So much thrombin means so much fibrin being generated. Okay. So this means so much clots. All right. So a lot of clots start to form all over the place. And this means a lot of fibrinolysis will start to happen later on. So this means a lot of a plasmin starts to form. Plasmin is the hero of the story. So when a lot of a plasmin starts to be activated, plasmin does not differentiate between fibrin and fibrinogen. Plasmin starts to randomly cut fibrin and fibrinogen all over the place. But then you might think, yeah, but this does not happen in a normal case, right? Yes, because in normal case, plasmin is restricted to the surface of the clot. But when you have so much plasmin, the body can no longer control it. So plasmin starts to flow in the normal circulation. So plasmin starts to cut fibrin and fibrinogen at the same time. All right. So see, plasmin starts to cut even fibrinogen, which is not a normal state. Plasmin cutting fibrinogen is not a physiological state. This is not normal. So when we see in the patient blood fibrinogen degradation of products, this usually is a reason for concern because this is not normal. This means too much coagulation is happening or too much fibrinolysis is happening. Neither of which is good. Okay. So what does this really tell us? When this, just briefly for you to understand what this is about, when the clot starts to form, we start to form fibrin monomers, FM. FM is fibrin monomers. So fibrin monomers start to form, then the clot starts to form. Okay, this is time passing. As we go from left to right, time is passing for the patient. So fibrin monomers start to form, then the clots start to form. Then later on, fibrinolysis starts to happen. Fibrinolysis starts to generate fibrin degradation products and fibrinogen degradation products in some cases, plus D-dimer. Okay, so we start to form fibrin, then the clot forms, then the degradation of fibrin and fibrinogen starts to happen. So when I detect the D-dimer or the FDPs, then this means a clot at some point started. So if I measure fibrin monomers and they are very high, I know coagulation started. When I measure D-dimer and FDP and they are high, I know that the clotting happened, then fibrinolysis happened, okay? Because we have an assay for fibrin monomers, we have an assay for fibrin and fibrinogen degradation products, we have an assay for D-dimer, as you know, okay? So what really happens, what fibrin and fibrinogen degradation products really tell us? Fibrin monomers itself just tells us that there's a lot of fibrin, but to be quite honest with you, as of now, there is not enough clinical evidence to give it a lot of clinical value. So yes, fibrin monomers tells us, okay, there's a lot of fibrin, but how can we use that clinically? There is not that much research available as of now. However, for fibrin and fibrinogen degradation products, the FDP assay, we can detect FDP presence in the majority of sepsis or DIC patients. So when we see FDP, you may or may not have sepsis or DIC. We have to verify that. D-dimer, we discussed D-dimer already. Okay, so we will not go over D-dimer again. So how do I really utilize this assay, the FDP assay or fibrinogen degradation products? You have multiple authorities. So this is Japanese medical something, and this is the same Japanese something, and this is the ISTH, International Society for Thrombosis and Hemostasis. They tell you, we have criteria that you can use to diagnose your patient for DIC. One of the criteria includes the FDP assay. This is where FDP assay is useful in the diagnosis of DIC and the follow-up for this patient. So the criteria, for example, include, does the patient have an underlying disease that can predispose them to DIC? If yes, we say 1 point. Does the patient have clinical symptoms? So and so, yes, you take this many points. Platelet count is very low, you take 3 points. So at the end, if you have, for example, more than 7 points to which FDP is contributing, so if you have more than 7 points, we say you have DIC. More than 5 points for the ISTH criteria, you have something called over DIC. For GAM, if you have more than 4 points, you have DIC. So this is where the value of FDP is. By the way, FRM is fibrin-related markers or fibrinogen-related markers. I forgot which. Anyways, so FDP is useful in this scenario. If you notice in this table, we don't have fibrin monomers because, again, we do not have enough studies to clinically utilize fibrin monomers. So as of now, the kit exists, but there is not that much research to back its use, to be quite clear with you. All right. So as of now, this is the main utility of the FDP assay. Now, moving on. Abnormal results. Last time we spoke about the mixing studies. We said, okay, PT, PTT, thrombin time, all of that. Now, how about D dimer? When D dimer is above the cutoff, when it's abnormal, what do we do? For the lab itself, there is not really that much to do. Because D dimer, the moment you release it and it's positive, really the management of the patient is in the hand of the clinician. And then we go with imaging, we may give the patient anticoagulants and so on and so forth. It's not like PT and PTT, because PT, PTT, when they are prolonged, we can run a mixing study because it can give us an idea. All right, we don't need the input of the clinician at this stage all that much. So for D-dimer, there isn't really that much that you can do in the lab in terms of reflex testing, unless, for example, the clinician is suspecting that maybe this patient has DIC, let's say, for example. So I want to also order FDP, all right? Or I want to order this test or that test. So there isn't a standardized algorithm. If D-dimer is positive, run this kind of testing. That does not exist really for D-dimer, okay? Some labs have their own policies based on the clinician's approach. Some hospitals, they have their own policies, but this is not a standardized approach. This depends on the lab. How about FDP? Now, I explained this to you a couple of minutes ago, okay? We say that FDP is used in this context, really. This is the only real use for FDP as of the moment, as far as I know, at least. Then if FDP is high, what do I do? Now, FDP on its own, if it's positive, it doesn't really give you much information. FDP is really useful in the whole context of the patient's case. We cannot just run FDP and say, oh, okay, the patient has DIC. It's a very useful test. No, FDP has to be looked at within a bigger picture, within the clinical picture of the patient and within the lab results that I obtained also for this patient. So FDP is just one part of what the patient is going through. We cannot just use it on its own. All right. And it's the same scenario with D-dimer. If FDP is high, all right, the next step is really in the clinician's hand. Okay, I can use, for example, this table to help diagnose the patient with DIC. Then I will follow them. Maybe I'll give them anticoagulants and antibiotics to resolve their sepsis and so on and so forth. So the work is really much more clinical than it is a lab involved work. Okay, so if there's a follow-up testing to be done after FDP is positive, really it depends on what the clinician wants to see with this patient. It's not something that we can do as a standardized approach in the lab. Okay. Now, we will be moving into a different section really that has to do with factor deficiency and inhibitors. So we will be moving away from fibrin or fibrin-related markers. Do you have any questions as of now? Or shall we move on to the factors part? Everyone is good?
Yeah, I have a question, right?
Sure.
Regarding this FTP and D-dimer, we have
Mhm.
noticed that in cases with respiratory distress, that these values are elevated. So how
Mhm.
to identify whether the sample is correct, or we can issue the result just based on the this clinical diagnosis? Can we issue the result like that?
Now, see, for D-dimer in general, the only claims you can possibly make is when it's positive, I don't know. You just report the result as it is to the clinician. The clinician has to work with the result. You can do nothing with it. And you have absolutely no clinical trials that are solid enough to tell you that in this particular case, for example, when the patient has respiratory distress, if the dimer is less than this much, you can do this, and this is what's going on with the patient. If it's more than that, this is what's going on. No clinical trials, no real good studies exist for this. All right. So it
Yes.
really is up to the clinician at this stage. You just release the D-dimer result, whatever it is for this kind of patients, and you cannot really say much. You cannot do much unless it's negative and the patient is an outpatient with low to moderate pretest probability. We can only say that it's exclusive of PE and DVT. We cannot say anything else. It doesn't tell us anything else. We don't have anything that backs up any claim that we can make in this case.
What about
So
FTP and fibrinogen?
in this particular case,
No, no. In general, when the results are coming above mixed level, how do
For
we report those kind of samples? About the linearity, how do we report those samples? Sometimes we find it in respiratory distress, pneumonia, and COPD.
Hmm.
In those kind of cases, that the femnogen FTP is also elevated.
Mhm. So you mean just
So,
how to report it, nothing beyond that, nothing clinical, just the reporting.
so we can rule out that the sample that is the correct result without the sample being affected or not, right?
And now see, for fibrinogen, okay, generally there are a few interferences for the
Okay.
fibrinogen assay, the Klaus assay, the one that you are using currently, okay? But
Okay.
clinically, I really don't know. Because don't forget that fibrinogen is an acute phase reactant, okay? So if the patient is having a severe case, the fibrinogen might be elevated because of what's going on with the liver, okay? It might be pumping a lot of fibrinogen. So what does that tell you clinically? Honestly, I don't know much about these particular cases, okay? But you can report it as it is. But to report it, let's say your reportable range is up to 80 grams per liter, for example, you just say more than 80 grams per liter. What can I do as a lab? You cannot really do much. If we have a non-interference in this case, for example, for these patients, then okay, we can put a note that the result is still, we can say the result is more than, let's say, 80 grams per liter. But let's say, for example, these cases are known to interfere with this assay, so proceed with caution. This will be told to the clinician, for example. Same situation applies to FDP, okay? Because clinically, of course, as you know, we cannot do much in the lab, all right? But if we know that this particular case is causing interference, we will still report the result as it is if we know that we cannot do much. And we just say the result is more than this much, but proceed with caution because we know that this might be an interference. If there is something that we can do, to give you a small example, D-dimer, if there is lipemia, some studies show that you can do high-speed centrifugation, then you run the sample again to remove the lipemia, and the results will be relatively accurate. But in the case of FTP, I'm not sure you can do much. And the case of fibrinogen, I'm not sure you can do much, and the interferences are limited. So you just report things as they are. You say more than this much, more than the upper reportable range, all right? And you just say, if we think there's an interference, you just say, we think there's interference. That's all we have for now as a lab.
Okay, thank you.
You're welcome. You're welcome. Anyone else has any questions, or should I proceed?
I think we can
Okay.
proceed.
Sure, I will proceed with this bit then. So moving into factors. So before I speak about factor deficiency and factor inhibitors and what's the difference, how do we deal with them? Now, what is really a factor assay? Now, of course, you know, we have factor 8, factor 9, factor 7, all of these. Sometimes we get requests, how much is the factor 7 in my patient blood? How much is the factor 8? And all these requests. Now, factor assay is very simply a modified PT or APTT assay. And the modifications are simple. If you look here, for PT or APTT assays, normally we do not dilute the plasma sample. For factor assays, we usually dilute the plasma. Okay, so for example, in Stago case, we dilute the patient plasma 1 to 10 before I run the factor assay. Of course, the machine does it for you. You don't do it by yourself. But compared to a regular PT or APTT assay, in the PT or APTT, the routine ones, we do not dilute the plasma. So this is the first difference between factor assays and regular PT APTT. The second difference is for the factor assay, on top of my diluted patient plasma, I add something called factor deficient plasma. In your regular PT APTT, you don't add anything. You just add your plasma, which happens, of course, inside the machine. We just add the plasma and we add our reagent on top, which will be the PT reagent or the APTT reagent plus calcium chloride. So these are the two main differences between PT and APTT and the factor assay principle, okay? So when I say a modified PT or APTT assay, because I still use the PT reagent, I still use the APTT reagent, but I have these two modifications, all right? Now, why exactly I do these modifications? This will require a lot of explanation, so it's a bit out of scope for now. So a typical factor assay is I dilute my sample, I add it into the tube, I add on top of it a factor deficient plasma. I have factor 8 deficient plasma, factor 5 deficient plasma, factor 2 deficient plasma. So for factor 2 assay, I use factor 2 deficient plasma. Factor 8 assay, I use factor 8 deficient plasma. All right. Then after these two are mixed, I add my PT reagent or APTT reagent, then calcium chloride, and just your very typical PT-PTT test. Okay. Now, what is really a factor deficient plasma? Factor deficient plasma is actually a plasma that's collected from human donors, but I remove from it the factor that I'm trying to measure in the patient blood. So when I mix my patient plasma with the deficient plasma, let's say I'm running a factor 8 assay, the only source of factor 8 will be my patient, because for factor 8 assay, I use factor 8 deficient plasma. So the factor 8 deficient plasma has no factor 8. The only source comes from the patient. So I'm really measuring in this assay the factor 8 that comes from the patient blood. That's how a factor assay works. Without a factor deficient plasma, you cannot run a coagulation factor assay. Simply, it's not possible, okay? So this is a very simple explanation of the principle of a factor assay. Now, when do you really need to run this assay? Why don't I just use PT, APTT? Now, of course, as you know, when I run PT or APTT, when they are prolonged, do you know what factor is missing? You don't know, because there are screening assays that give you a general idea about the extrinsic, the intrinsic, and the common pathways, but they do not tell you what is the problem. Do you have a problem with the quantity of one of the factors? Do you have a problem with the function of one of the factors? We have no idea. We just know that there's a problem. PT and APTT are normal. We say everything is okay. One of them is abnormal. We have to check, is PT abnormal? Then maybe it's the extrinsic pathway. APTT is abnormal. Maybe it's the intrinsic pathway. Both are abnormal. Maybe it's the common pathway. You know, of course, these things. But we don't know which factor is missing, which is the reason we need the coagulation factor assays for, because the coagulation factor assay tells me that specifically factor 8 is missing, specifically factor 7 is missing, specifically factor 11 is missing, okay? But PT, PTT do not tell you that. This is the reason we need them, all right? Now, does that mean that every PT result that is a prolonged, I go and run all the extrinsic pathway and the common pathway? Of course not. Of course not, because it's too expensive and takes too much time. We cannot just do that for every patient. So this is where your mixing studies come in. So if you remember last time we said, if my PT is a prolonged or a PTT is a prolonged, first thing I do is I run a mixing study. Mixing study tells me one of two simple things. If the mixing study is corrected, then this means the reason of the prolongation in my PT or APTT was a missing factor. If the mixing study is prolonged, then I say most probably, and again, notice I said most probably, I did not say for certain. If the mixing study is still prolonged, I say most probably I have an inhibitor in the patient blood that's interfering with the assay and causing a prolongation with the mixing study. All right, so if my mixing study is corrected, I know, oh, okay, it's a coagulation factor that's missing. Then based on the prolonged assay, I will go run the factors which are relevant. So if PT is a prolonged, but APTT is normal, the only relevant assay in this case is factor 7. So I don't need to run all factors. I just run coagulation factor 7 assay. So this is the stuff we spoke about in the last presentation regarding the mixing studies. So we will not repeat this here. Now, as I just said, if mixing study indicated that a factor deficiency exists, then we just run the relevant factor depending on what assay was a product. This is quite obvious. So if the mixing study indicated the presence of an inhibitor, then what do? I will not run a factor deficiency assay, because consider the following situation. Mixing study is still prolonged. If I run a factor assay, I would like to hear your answer, by the way. If I run a mixing study and the mixing study was prolonged, let's say that I wanted to run a factor assay. So let's say the APTT was prolonged, PT was normal. So I run a mixing study for APTT, and the APTT mixing study was still prolonged. What do you think I will get the result for factor 8 assay if I run a factor 8 assay in this case? I want to hear your opinion. What do you say? Will it be normal? Will it be corrected? What will happen with it? Will it be high? Will it be low? What do you think?
It will be prolonged
Why is that?
because in case of if there's an inhibitor, it won't be corrected, right?
Yes, exactly. It's the same situation as with the mixing study. If you have an inhibitor and you run a coagulation factor assay, then the inhibitor will still inhibit your coagulation factors. So if you run your coagulation factor assays when you have a mixing study that's prolonged, then the clotting time in the factor assay will be prolonged, which means you will have a falsely low factor assay. So you have to be very careful with factor assays when you have a prolonged mixing study because you may be reporting a falsely low result. All right. If the clinician insists on a factor assay in this case, you have to tell them that we are suspecting an inhibitor because mixing was prolonged. So this factor assay that we are reporting to you may be falsely low. Okay, this is a very important point that you have to consider. So when I say inhibitors, I am not referring to the natural coagulation inhibitors, the natural anticoagulants in your blood. Do you know what are the natural anticoagulant inhibitors I'm referring to here? What are the proteins in your blood that are acting as anticoagulants? Because this will be relevant in the next section. Even if you want to write in the chat, it's fine, feel free. Give me an example or two.
Is it
Sorry?
protein S?
Yes,
Protein C?
exactly. So we have protein S, we have protein C, we have antithrombin, exactly, okay? So these ones, protein C, protein S, and antithrombin, they usually do not have any effect on your regular coagulation assays. If antithrombin is low, your PT and APTT will be normal. Protein C or protein S are low or defective, your PT and APTT will be normal. So they have absolutely no impact on your factor assays. However, the inhibitors that we are referring to here are inhibitors which are not physiological ones. They are not normally present. So for example, lupus anticoagulant is one inhibitor of your coagulation assays. Lupus anticoagulants are pathological. They are not physiological. They are not normally present in the blood. For example, heparin is an inhibitor in this case. Okay, heparin is a medication. It's not normally present in the blood. Direct oral anticoagulants like rivaroxaban and apixaban and dabigatran and argatroban and all of these are anticoagulants. They are not physiologically present in the blood. So the inhibitors I'm referring to here are things which are not physiologically present that can cause a clotting prolongation even after mixing is done. All right, so this is what I'm referring to when I say inhibitors. So mixing study is prolonged. Okay, what do I do next? Do I run a lupus anticoagulant assay? Do I run anticoagulant assay like the antitin A or the anti-2A, the heparin assays, the DOAC assays? What do I do? Now, this very much depends on the context of the case. For example, I do not just run lupus for every patient because lupus testing is expensive and complicated. I cannot just run lupus every time the mixing study is prolonged. I have to check what is the patient's situation. Is this patient, for example, a known patient who has a lupus issue? Does the patient have a high suspicion of lupus? For example, patients who have systemic lupus erythematosus, a lot of them have lupus. So this is a patient that is highly suspected of lupus. Lupus anticoagulant assays in this case is reasonable because we have a high suspicion. For example, if the patient is taking heparin, then we don't go test lupus because the patient is taking heparin. We will go quantify the amount of heparin in the patient's blood. Okay? So the context of the patient, what's going on with the patient, determines what we can do in this case. All right? We don't just test everything under the sun. We cannot because it's costly, it's a waste of time, and it's not recommended to just test everything. It doesn't make sense. So we will start with them one by one. So the inhibitors that you normally would encounter in the lab are anticoagulants like heparin or DOACs, lupus anticoagulant, all right, or anti-factor antibodies, for example. But these are much rarer. These are antibodies that are formed against your coagulation factors. So for lupus, when do I test for lupus? Again, I will not just test everyone for lupus. Actually, the recommendations of the ISTH is that do not test for lupus unless you have a reason that is good enough for you to test for lupus. And the reason behind this is lupus anticoagulant testing still reports a lot of false positives. Okay, and we want to avoid the false positives in these patients, because a false positive means the patient might go for anticoagulant treatment, and this is unnecessary in this patient, which might put the patient actually at a bleeding risk. Okay, so unless I have a good reason to test for lupus, I am not recommended to test for lupus. So when am I recommended to test for lupus? One, if the clinician treating this patient requested lupus testing because he's suspecting that this patient may have a lupus anticoagulant. Okay, so that's situation one. The clinician is the one requesting because they have a reason to suspect lupus anticoagulant. The second reason, if I'm doing a PT-PTT, then one is prolonged, then I do the mixing. Mixing is prolonged, but I know very well that the patient, for example, is not taking anticoagulant. I know the patient very well is highly unlikely to have anti-factor antibodies, for example. Then in this case, lupus seems to be the most likely reason for the prolongation. Okay, so in this case, I can go for lupus screening assays, and I will take it from there. Okay, so this is about lupus anticoagulant. Now, what could interfere with my lupus assays? I will not, of course, I will not speak about lupus anticoagulant assays here in details. This is a very, very long topic, and we will not go through it. Now, what could interfere with my lupus assay? CRP, C-reactive protein, functions very similarly in the context of the APTT test, very similarly to your lupus anticoagulant. Okay, if you know, lupus anticoagulant binds to negatively charged phospholipids, which interferes with your coagulation assist. CRP as well binds to the negatively charged phospholipids, and it blocks your coagulation factors from binding to these phospholipids and doing their function well. So CRP functions very similarly to lupus anticoagulant. That's why assays which are low in the negatively charged phospholipids are very sensitive to the presence of CRP. For example, for Stago, PTT Automate has low amounts of phospholipids. That's why it can be affected by CRP values from 85 milligrams per liter or higher. Okay, so if the patient has any kind of severe inflammation, apologies. If the patient has any kind of severe inflammation, then PTT Automate will be prolonged. Whereas CKPRIS will probably be normal because CKPRIS is rich in phospholipids, making it insensitive to CRP or to lupus as well. So CKPRIS is insensitive to lupus, very poorly sensitive. PTT Automate is very highly sensitive to lupus and to CRP because in context of APTT, CRP and lupus anticoagulant function very similarly. Okay? Not biologically, in the context of APTT. Now, the other suspect in the case of mixing studies being prolonged is anticoagulants that are given to the patient. And notice that I said heparins and DOACs. I did not say something like warfarin. Do you know why? Can you tell me why warfarin is not considered as an inhibitor in this case? I would like to hear from you. Warfarin is an anticoagulant, of course. But why is it not suspected here? I will give you a small hint. What does warfarin exactly do in the patient blood? What is the physiological effect of warfarin on the patient blood? What does it do? Even if you have half an answer, it's fine. As long as you start thinking about it, this will be important. No answers? Okay, no worries. I will tell you the answer. What warfarin really does in the patient blood is that it reduces the level of functional coagulation factors. Okay? So warfarin doesn't really inhibit coagulation factors. It doesn't stop them from doing their work. It just makes your body produce dysfunctional coagulation factors. So when I do my mixing study, I am actually adding all the necessary coagulation factors to get a normal mixing test result. So when the patient is taking warfarin and you do a mixing test, you are adding all the necessary coagulation factors when you do the mixing. So the result will be absolutely normal if the patient is taking warfarin. Whereas heparins and DOACs, direct oral anticoagulants, they actively inhibit coagulation factors. They don't reduce the production, they inhibit the coagulation factors. So even if you do mixing, even if you add all the factors that you want to add, heparin will still inhibit, same for DOACs. So these two will still inhibit the coagulation factors that you add in the mixing study. That's why heparins and DOACs will cause a prolongation in the mixing studies. Okay, that's why if your mixing study is prolonged, one of the suspects are heparins and DOACs. So if I know, for example, that the patient is being treated, let's say, for example, for a clot that happened, like a PE or a DVT, and the patient is taking something like a Clexane or unfractionated heparin drips, then in this case, it's very clear that the mixing is prolonged because of heparins or DOACs. Okay. Now, of course, how much each of these drugs, like a Clexane and this and that, and IV injections of, IV of UFH, each of them have different levels of effect depending on the dose, depending on the test that's being done, but they still inhibit coagulation factors. Okay, so if the patient is taking them, they are likely to cause an interference with the assay depending on the drug. So if we are suspecting an anticoagulant, we can just very simply ask the patient or the staff in the hospital, is this patient taking an anticoagulant? Okay. So if they say yes, then that's it. We found the reason of the prolongation of the mixing study. The same applies to DOAC, meaning that you can simply ask the patient, do you take any anticoagulant? The patient says yes. That's it. I found the reason for my mixing study prolongation. But again, that depends on the drug and the dosage and many other factors. But still, it can cause an interference. If the patient, for example, cannot be asked, or the hospital staff do not have this kind of information, then I can run something like thrombin time assay or an antitin A assay. These are anticoagulant screening assays, or anticoagulant in the case of antitin A, anticoagulant quantification assays. Okay. So if both of them tell me that no, there is no anticoagulant in the patient's blood, then I will start to suspect something else, like lupus, for example, or antifactor antibodies. Okay. So it starts to be, let's say, a process of exclusion. I excluded heparins and DOACs. Okay, what's the next possible thing? Lupus is the next possible thing. Why did I not think of antifactor antibodies? Because antifactor antibodies are very rare. Lupus is much more likely. So I start to exclude things one at a time. I go on lupus. Is lupus positive? No, lupus is negative. Then I'll start to suspect, for example, antifactor antibodies, because I excluded the heparins and DOACs and lupus. Okay. Now, next step, antifactor antibodies. Now, a small detail. Antifactor antibodies are antibodies that target any of the coagulation factors and inhibit their function. So antifactor antibodies, very simply, are antibodies that go and bind one of your coagulation factors, such as factor VIII, this is the most common one, and actually inhibit its function, because don't forget, antibodies are quite large. So they will physically sometimes interfere with the function of the antibody. Sometimes they will cause it to be cleared out of the circulation. Okay, the mechanisms are many and complicated. This is not our topic. Now, who will have this kind of antifactor antibodies? Most common cases are patients who have deficiency in this particular factor. So for example, patients who have severe hemophilia A, severe deficiency of factor VIII, so less than 1% of factor VIII, 30 to 40% of them, they will develop antifactor antibodies. And this is a real big problem, because if you give this patient an infusion that contains factor VIII, for example, okay, the antibodies will still inhibit it. So the infusion is useless. Okay. So this is a problem. These patients are given a special kind of medication. All right. Antifactor antibodies can also develop against other factors. They can develop against factor 9, 11. There are even reported cases of antifactor antibodies against von Willebrand factor. Okay, so they are simply antibodies that can bind the coagulation factor and inhibit its function, which of course will interfere with your PT or APTT, depending on the factor that's inhibited. Because if I inhibit one of the factors, I will prolong the clotting time. Okay. Now, these are quite rare. Again, anti-factor antibodies are quite rare in the population. Some of them are, maybe one in a few million patients that you will have this issue. So they are very rare. And sometimes they are developing in people who are completely normal, but these are quite rare cases. So some people who are completely normal, sometimes they will have something called acquired anti-factor antibodies. They have absolutely nothing. All of a sudden, they developed an antibody, but these are very rare. So how do I detect or check for this anti-factor antibody? The only choice that I have is something called Bethesda assay. Maybe you have heard about it before. All right. So Bethesda assay is quite long. It's a bit complicated, requires a lot of work, poorly standardized, but it's really the only thing that we have at the moment to work with anti-factor antibodies. Okay. So as I told you, they are rare. So we do not start testing with the Bethesda assay unless we exclude the anticoagulants, we exclude the lupus, and the only suspicion we have left is anti-factor antibodies. So this is what I told you about the Bethesda assay. The last important point about Bethesda assay is that, again, it's not very standardized. The results can be quite inconsistent from run to run within the same lab. So you can expect the results between labs will be quite inconsistent. And this is one of the main problems with the Bethesda assay, apart from the cost and the complexity. So unfortunately, that's the only solution we have right now. Now, I think it would be a good time to have a 10-minute break before we go through with thrombophilia. Is that okay for you, or do you want me to go through? It's up to you.
It's okay for us. We have a few questions. Is
Absolutely,
it
yes.
okay?
Yeah, sure.
Okay.
Yeah, when you said that the physical inhibitors such as heparin and DOAX can cause elevated levels, right? So,
Mhm.
what would be the recommendation when to test if the patient is taking heparin or DOAX?
You mean
How
where
would
should I
we,
suspect the presence of these?
yeah.
Hmm.
If the
hmm.
patient is taking those medications, how do we
Hmm.
advise them to collect sample?
Okay, see, now this is very much dependent on the type of medication they are taking. For example, to properly quantify the level of unfractionated heparin, all right, the standard protocol is after 3 to 4 minutes of the injection of unfractionated heparin, then you collect the sample from the patient because that's the time the unfractionated heparin is at its highest. Okay, not 1 to 2 hours after, not 6, 7 hours after, 3 to 4 hours after. Now, the issue is not here. The issue is that the anticoagulant is present or not. Okay, so how do we test it? There's a lot of complexity about testing because there are many differences between the drugs. The idea is that the problem is PT or PTT are prolonged. Mixing is prolonged. We just want to know, does the patient actually have an anticoagulant or not? So for you to know when to collect depends on you knowing what is the anticoagulant the patient is taking. And that usually depends on asking the hospital staff, let's say the nursing staff, what is the patient taking? Okay, because usually heparin is not administered by the patient themselves to themselves. It's usually administered, especially for UFH, it's usually administered in the hospital. Okay, so that usually is useful if you ask the nursing staff, or we can ask the patient, do you or are you prescribed any kind of anticoagulants? Okay, if yes, if we have a suspicion, if we have a reason to suspect that, then we will test using an anti-10A assay or a thrombin. If we really don't know, then we have to use all the assays that can check for anticoagulants. That will be, for example, anti-10A or thrombin time as of now, okay? Because thrombin time will check for everything that inhibits thrombin, anti-10A will check for everything that inhibits anti-10A. So there are some details in this particular topic, but the when is very much dependent on the drug. So I cannot just tell you after 4 hours for all of them. That does not exist.
Usually we get a lot of outpatients, so
Hmm.
we get some patients who are on DOAX. So that's the
Hmm.
thing. Because sometimes the doctor won't request the sample to be collected at a certain time. So when we get an elevated or for a prolonged time, we
Hmm.
usually collect another sample. So to avoid this resampling, can there be anything done prior to the first sample collection?
Prior to
Can
the
we
first sample
advise?
collection.
Yeah. Can we advise the patient if the patient is taking any drugs to come after certain time? Is there
Now,
any?
I imagine without patients that will be quite difficult because it's hard to control that without patients. Now, let's say you cannot control that. Okay, so the only situation you have is that you receive the sample, you start analysis immediately, and you suspect that there's an anticoagulant. Now, to avoid resampling, your best choice is to start running the anticoagulant assays, such as antitin A or thrombin. If either of them gives you an indication that the patient has an anticoagulant, if we cannot, let's say, ask the patient directly, because it will be impossible to ask each and every patient. So let's say we have a suspicion because antitin A gave you a result or thrombin time was prolonged. So we have a suspicion that there's an anticoagulant. At this stage, we might reach out to this particular patient, let's say, or the nursing staff that was taking care of them. Does this patient take an anticoagulant? Yes. Let's say the patient is taking Clexane, for example. I know that to quantify Clexane, I have to use antitin A assay and I have to collect the sample, let's say, after 4 hours of injecting the patient. So this will be really your only way because depending on the anticoagulant they are taking, the protocol can be quite different. So you cannot really put one standard approach for all patients that, okay, when you come, you have to collect the sample, let's say once in the morning, 5 hours after you take the medication. It's really hard to control such a thing. I'm sure you know. So it really depends on the case, and you have to consider the practicality of the situation.
Okay, one more question.
Sure.
So after we have done the mixing study, the results are corrected. So do we straightly go into vector assay, or do we consider the like liver function or vitamin K status of the patient?
Now, see, for example, if we know for sure that the patient is taking warfarin, for example, okay, then this is a very obvious study for the correction of the mixing study, because we know the warfarin reduces the level of functional coagulation factors, okay, and the patient does not have a history of a bleeding, for example. We have no reason to suspect that the patient has a factor deficiency. Then in this case, there is no sense to run factor assays, okay, because we understand the situation of the patient. We understand that it's warfarin that's causing this. I forgot what's the other point that you said about liver function. If you know, for example, that liver function for this particular patient is compromised, okay, then when you run a factor assay, let's say factor 8 is low, all right? Now, it says factor 8 is low, you report to the clinician factor 8 is low, but we are suspecting, yes, that factor 8 would be low because liver function is compromised. So it depends on what you are trying to get. What is the information that you want to know in this case? So you run it, yes, it's low, but we know it's because of liver function. It doesn't really provide you much more information, but that also depends on what the clinician wants to see. Maybe the clinician wants to monitor something specific and they know that the liver function impacts factor 8. So it really depends on the situation of the patient. But if we know that the patient is, yes, tell me.
Yeah, so while we report the mixing studies, do we just put a comment to consider those things, or just we
Now,
say it's corrected? Is it?
see, mixing studies usually, as far as I know, mixing studies by themselves are not very useful to the clinician because a lot of clinicians, they don't know what a mixing study is really, unless they are really heavily involved with the lab. So ideally, it's the lab's responsibility to tell the clinician that we are suspecting a factor deficiency, for example, or we are suspecting an inhibitor if that's relevant. If you don't have factor assays, for example, or you cannot order factor assays, or the insurance doesn't cover them. Okay. But to report the mixing studies directly to the clinician, as far as I know, is not usually very useful, usually for the clinicians, for the treating clinicians. But that really depends on the hospital, depends on you guys. So what factor assay do I run? It really depends. It's a very complicated scenario because to give you a small example, I have some hospitals who know that I need to run a factor assay, but the insurance doesn't cover it and the patient doesn't want to pay for it. So they end up reporting the mixing study by saying the patient is suspected of factor deficiency and they stop there. If there's an inhibitor, they might stop and say we cannot report. It's inconclusive. So it really depends.
Okay, thank
Clear?
you.
Good. You're welcome. You're welcome. Any other questions?
No.
All right. Okay. So we will go now into thrombophilia. This one would be interesting. Now, thrombophilia, very simply, as the name implies, thrombo comes from thrombus or clot. All right. Philia
Like
comes from the yes,
like
yes. Hmm.
do you want a break? We were talking
For
for
me, I
5
don't
minutes.
mind. If you
Okay.
want, I can give you a break. It's up to you guys.
Okay, then we will continue.
Sure, sure.
Okay. We will take 5 minutes break. Is that okay?
Absolutely, absolutely. Yeah, yeah, absolutely. I will wait
Okay.
for you here. No problem.
Okay. Thank you.
You're welcome. You're welcome.
Light. Shall we start?
Assalamu alaikum.
Alaikum assalam.
Yes, yes. Can you hear me well?
Yes.
Okay. Okay. Yes, sorry. So can everyone hear me and see the presentation? I can continue?
Yes.
Yes.
All right, okay. So we stopped at thrombophilia. What I was saying is that thrombophilia is, as the word implies, broken into two parts. And as you know, thrombome is, or refers to thrombus, that's a clot. Philia is the affinity. So people who have thrombophilia simply have a higher chance than a normal person of their age, or if their gender, for example, or of their case, to have a thrombus. Okay, so for example, someone who is less than 50 or 60 years old is not likely to have a clot. So someone who's 25 or 30 years suddenly starting to develop clots is not something that is normal. So we say this patient, for example, or this person is suspected of having thrombosis. So we'll have to check them or we have to diagnose them. So thrombophilia is a tendency to have thrombosis. Now, this can happen generally because of two reasons. Either your natural coagulation inhibitors, or what we normally or generally refer to as the brakes of coagulation. So either the brakes of coagulation are not functioning very well, so coagulation can proceed uncontrolled, or we may have something like lupus anticoagulant, or as a consequence of activated protein C resistance that promotes or pushes thrombosis to higher than its normal, let's say, or to higher chances than normal. So we either have a problem with the natural anticoagulants in the body, antithrombin, protein C, or protein S. They might be low in numbers, or maybe they are dysfunctional. Or we maybe have something like lupus anticoagulant, which can trigger thrombosis. Or maybe you have something like activated protein C resistance, where protein C is working, but factor V resists the inhibitory effect of a protein C. So this disposes or predisposes the patient to having thrombosis. So when do I suggest that this patient needs a thrombophilia screen or a thrombophilia test? Now, this generally depends on the history of the patient, what is happening with the patient, what is going on with their family, for example. Do they have a history of having clots when they were young, etc., etc., etc. So this generally depends on the presentation of the patient, the clinical image of the patient. So usually thrombophilia requests come from a clinician. I don't usually run a protein C or a protein SSA because I have a prolonged mixing study. As I said previously, protein C, protein S, antithrombin, they do not have any effect on PT-APTT. Lupus, of course, is a separate case because it can affect APTT. But generally for thrombophilia, it's because the patient had an event that might trigger our suspicion that this patient is a thrombophiliac. So as you can see here, for example, you have some guidelines that suggest, okay, if the patient has this, if the patient has that, if the patient has a provoked or unprovoked VTE, check this, check that. So as you can see, there's plenty of stuff. We will not go through that, okay? So if, for example, the patient had an unprovoked case of thrombosis, okay, and the site of the thrombosis was abnormal, for example, like in the arms, okay, then we can check for a few things, then we can check for this, we can check for that, then we'll go through some thrombophilia screens, okay? They can be our tests or they can be genetic tests and other kind of testing, etc. So usually the decision is taken by the clinician that saw the patient case and not the lab. Because again, this is not a kind of testing that you would do as a reflex because of results of other tests. So as previously said, thrombophilia tests include antithrombin, protein C, protein S, lupus anticoagulant, activated protein C resistance. We will not go through the others because they're not commonly needed or commonly used. One note that I want to mention to you, protein S is a bit unique because protein S in the circulation exists in two forms. There is something called free protein S, I'm sure you have heard of it, and there is something called bound protein S. Now, in the circulation, there is something called C4b binding protein. Again, in the circulation, there's a protein called C4b binding protein. This protein normally binds some of the protein S and basically makes it dysfunctional, or not dysfunctional, it inhibits its function or stops it from doing its function. Whereas free protein S circulates without being bound to C4b binding protein. Only free protein S is active. Okay, so free protein S can do the function that we expect of protein S, which is a cofactor of a protein C. Bound protein S, which is around 50-60% of the total protein S in circulation, bound protein S is inactive. It's not functional. Okay, so bound protein S cannot function as a cofactor of protein C. So bound protein S is not functional. This is important because when we measure protein S using activity assays, that is clotting or chromogenic assays, we are only measuring free protein S. So when you run your clotting or chromogenic protein S, if that exists, okay, if it's an activity assay, then what we are measuring is a free protein S. Why? Because the bound form of protein S is inactive. It cannot do the function. It has no activity. So we cannot measure its activity because its activity is inhibited. Okay, so this is only unique to protein S. All the others do not have a free and bound. Only protein S has that. Now, when we are working with thrombophilia, we have to make a very important distinction. We have something called qualitative or activity assay, okay? And we have something that is only quantitative assay, okay? So we have assays that check the function or the activity of the protein, and at the same time, they tell us you have this much of the protein C or protein S or antithrombin. So we call this activity or functional assays. Why? Because again, they check the activity or the function or the quality of the protein that I'm measuring, plus they report its quantity. The other type of assays is only quantitative. This kind of assays cannot tell us anything about the activity of the protein. They are only quantitative. So the activity and the quantitative assays are generally clotting assays or chromogenic assays. These are the commercial names of these kits that we have, okay? So for us, we have stackled protein S, stackled protein C, and so on. The quantitative only assays, they are generally antigenic assays, okay? So antibody-dependent assays, like the D-dimer one. Why? Because when you quantify something using an antibody, the antibody cannot tell you anything about the function of the protein. It just goes and binds to the protein, but it doesn't tell you anything about how the protein functions. So these, we call them quantitative assays. And again, generally quantitative assays are antigenic. Sometimes they are chromogenic, but this is rare. So in our case, we have the LIATEST line. LIATEST stands for latex immunoassay. So whenever you see LIATEST, it's an antigenic assay. We have also acerachrome. Acerachrome, this is ELISA assays, okay? Stacklot means clotting assay. Stachrome means chromogenic assay. So these are the commercial names of these assays, and we'll break them down one by one. So another point that's related to the type of disease or how we diagnose or how do we describe the disease the patient has or the type of deficiency that the patient has. Whenever I say type 1 deficiency or type 3 deficiency only in the case of protein S, okay? So type 1 or 3 in the case of protein S, it's a deficiency, okay? That is a problem in quantity. So the protein is low in amount, okay? But its function is normal, no problem with the function. A problem only with the quantity. So whenever I say type 1 deficiency or type 3 deficiency, I'm describing an issue with the quantity of the thing I'm measuring. Whenever I say type 2 deficiency, this is a problem with the function of the protein. So maybe, for example, it has a mutation. The quantity may be normal, but the function is not normal because, you know, a mutation usually or sometimes would ruin the function of a certain protein or would reduce its function. So type 2 is a qualitative issue. It's an activity or function issue. Okay, so this is very important. Now, starting with the protein S. What assay do I test for a protein S? Do I start with an activity assay? Do I start with a quantity assay? Now I want you to consider the following situation. We will go back to this. If I have an assay that tells me your quality of the protein is good and the quantity of the protein is good, this is great, right? Because I get two things with one test. Whereas this kind of assays just tells you the quantity is okay, but it doesn't tell you about the quality. But the quality sometimes can be defective. Some people have mutations. So which do you think is best? I want to hear from you. Which do you think is best? If I start a protein S with antigenic or with a quantitative or with a qualitative and a quantitative assay? Now, of course, I know that you see the answer, but I want to hear your opinion. What do you think?
Qualitative,
Why is that?
because we know it is functioning. Like for protein S, you said the free uh, free protein S is only like active. The bound ones
Hmm.
will not be active. So
Okay, forget protein S. Let's talk about protein C, for example. So which do you think is best? Should I start with the quantitative and the qualitative assay, or should I go with only a quantitative assay? Principle is the same, but let's say we are talking about the protein C. What do you think?
so when we do the quantitative, we don't know whether it's functional or not. So better to start with the
Yes,
qualitative assay.
exactly. Absolutely, 100%. So when I start with a qualitative or a functional assay that also gives me quantity, that usually is the ideal starting point for me to test my patient. Because if the patient has a mutation but the quantity is normal, the quantitative assay will miss telling me that this patient is not normal. Okay. However, there are some points that I need you to consider here that might seem counterintuitive. For example, for a protein S, as you can see written on the slide, it says, generally, some studies suggest that it is not recommended to start with activity protein S assays. The lab should start with antigenic protein S. Now, that doesn't make much sense based on what we were just discussing, right? Because ideally, theoretically, I will start with a qualitative and a quantitative assay. Because what if the patient has a qualitative assay? I will miss it if I use an antigenic assay, which is only quantitative. Now, there is a good reason behind that. As you can see, reason type 1 and type 3 protein S deficiencies are far more common than type 2. Type 2 is the only one that has a function issue. Okay, type 2 is very rare. Okay, even if it is very rare, I still want to detect these patients. So I still would want to check activity assays instead of quantitative assays. So why these studies suggest that I should use an antigenic protein S? The issue is this. Generally, protein S activity assays are very sensitive to a lot of interferences, which means we are at risk of reporting false positives in many cases, okay, which is not ideal, of course. So then, what are the suggestions? What should I do? Many studies suggest that you start with the quantitative assay, which would cover most of the patients who would have a problem with the protein S. But if the quantitative assay comes back normal, but the clinician who was treating this patient is still suspicious that maybe there's a problem with the protein S, then we keep in the lab an activity protein S assay. And when the clinician is suspicious that no, quantitative assay is normal, but I'm still suspecting this patient may have um, a qualitative issue, a function issue, at that point only we would run an activity assay. If the patient has a qualitative issue, we would detect it at that point. So this is what these studies are suggesting. By the way, if you look at the slides, there's on the lower left corner in blue, it says check notes. I will, of course, give you all of these slides at the end. In the notes under the slide, you will see a lot of very relevant details that tell you why is the content of the slide saying what it's saying, okay? Because there are some details that would be good for you to understand. Is the case of protein S clear for you? Because this is very important for you to know. Do you have any questions about this? I don't want to move to the next ones, but this is still not very clear.
Yeah, it's clear.
Good?
Good.
All right, excellent. Now, moving to protein C. Protein C case is simpler and makes more sense. It's more intuitive. Protein C, when we run an activity assay that is STAC-CHROM or STAC-CLOT, which is chromogenic assay or clotting assay, usually this assay is sufficient. Antigen assays for the protein C are generally not needed. And actually, for your information, we do not have an automated antigenic assay for a protein C from Stago. What's the reason? Because for us to distinguish between type 1, which is a quantitative deficiency, and type 2, which is a function deficiency or a qualitative deficiency, is not essential. Why? Because people who have type 2 protein C deficiency, which is a qualitative, are treated in the same way that we treat and we deal with type 1, which is a quantitative deficiency patients. So it doesn't really matter much to us to know if the patient has type 1 or 2, except for very, very rare cases. And in those cases, you have an ELISA assay. But these cases are very exceptionally rare. I have so many countries that do not even use this kit at all. Usually it's sent to some countries who have centralized testing for this, but this is very rare and beyond the scope of this discussion. Now, for clotting, for protein C, we have two assays, okay? For protein S activity, we have only one assay, which is only clotting. We don't have a chromogenic assay from Stago for protein S. For protein C, we have one that is called the STAC-CLOT protein C, which is a clotting protein C. We have one that's called STAC-CHROM protein C, which is a chromogenic protein C, okay? It's based on photometry. Which one is better? Now, chromogenic protein C is the one that is normally recommended, as you can see, recommended by local guidelines in UK and Italy, and by the International Journal of Laboratory Hematology. Why? First of all, it's much cheaper to run the chromogenic protein C assay. The clotting protein C is expensive, okay? Chromogenic protein C has an issue though. It detects all types of all cases of type 1 deficiency, which is a quantitative deficiency. However, some type 2 deficiencies, some qualitative deficiencies, protein C might miss them. Certain mutations in protein C cannot be detected by chromogenic protein C assays. They can only be detected by clotting protein C assays. See? The advantage of clotting protein C is that it detects all types of deficiencies, type 1, which is a quantitative, and type 2, that's a qualitative. This is the only advantage of protein C clotting. That's why sometimes it may be needed if this one says normal, but again, the clinician is still suspecting the patient of having a protein C issue, okay? So usually we would start with this based on these recommendations. If the clinician still is suspicious of protein C issues, we can go to the clotting protein C assay. Okay. The final important point is that the chromogenic protein C assays have less interference from things that interference with coagulation assays, because factor 8, lupus, direct thrombin inhibitors, and factor 5 Leiden can interfere with the protein C clotting tests. Moving on to antithrombin. Antithrombin pretty much has the same situation as it is with the protein C. Generally, we would work with activity assays, and for Stago's case, we have only a chromogenic assay. We don't have a clotting assay for antithrombin. And usually this is enough. Okay, an activity assay for antithrombin is enough. Antigen assays cannot detect type 2 deficiency. We know that. Okay, plus generally they are not really needed. As you can see, what's the reason? Distinguishing between types 1 and 2 does not affect patient management. So antithrombin and the protein C, they fall under the same situation. Okay, activity assays are enough. Antigenic assays are generally not needed, except for very, very rare circumstances, not relevant for us in general. Now, moving on to APCR, which is a bit different from the previous three that we mentioned. Okay, because if you notice with the protein C, protein S, and antithrombin, we are checking the function and the quantity of a protein. Okay, which is protein S, C, and antithrombin. APCR activated protein C resistance. What we are checking is the resistance of something towards the activity of a protein S. We are not measuring the quantity of something. We are measuring the resistance to the activity of a protein C. The resistance of what exactly? For your information, which is very important here. Protein C main function in coagulation is, or one of its main functions, it cuts factor 5 and factor 8 at specific locations. So protein C cuts factor 5 at the 3 locations, and it cuts factor 8 as well. Okay, for us, what's important here is factor 5. So when you cut factor 5 and when you cut factor 8, you basically disable them. So this means you are inhibiting coagulation. So protein C in this sense is an anticoagulant because you are inhibiting the process of coagulation by disabling this factor 5 and factor 8. Some people, they have a mutation in factor 5 in the place where protein C cuts factor 5. So protein C goes to do its job, it goes to cut factor 5, then it goes to the place where it needs to cut factor 5. But the protein C does not recognize this factor 5. This factor 5 looks strange. I will not cut it. Protein C is specific, means if it doesn't find a factor 5 that it recognizes, it does not cut it. So what happens? Protein C cannot do its job very well. So I cannot inhibit coagulation very well. So coagulation goes extra more than it should. So I have a little too much coagulation. A little too much coagulation is very simply thrombosis or thrombophilia, predisposition to thrombosis. Okay, so again, APCR is activated, the protein C resistance activated because protein C has to be activated to do its job. So when the protein C is activated and it goes to do its job, factor 5 looks different, so protein C does not do its job. So we say that there is a resistance to the function of a protein C. Why? Because factor 5 is mutated. So protein C does not recognize it, does not cut it. This causes coagulation to go a little out of control. We call this a mutation in factor 5, factor 5 Leiden. Why Leiden? Because it was first described in the city of Leiden in the Netherlands. Okay, that's where the first case was described for this disease. So APCR is a kit that is run as a regular clotting test, and the result is reported in second or a ratio depending on the manufacturer of the kit. All right. So this is what I just described to you. APCR assess the ability of so and so and so, what I described to you. However, one very important point. Do you see here what it says? Most APCR positive cases are caused by factor 5 Leiden, but not every APCR positive case is a factor 5 Leiden mutation case. If my patient is positive for APCR, or that is, they have a problem with the APCR result, they are not normal or out of the reference range, let's say, that does not necessarily mean that the patient has factor 5 Leiden. Some people, they have something that's called acquired APCR or acquired activated protein C resistance, okay? Out of the scope of this case, but some people like that exist. But these are very few people. The majority of the positive APCR cases are factor 5 Leiden cases. Okay, if you want to read more about this topic, you can see there are notes that are relevant. It would be good for you to know. So for our case, the APCR kit works as follows. I will run the patient, okay? If the clotting time of the patient is more than 120 seconds, according to Stago's cutoff value, I say the patient is normal. But that sounds very strange. I want to ask you now, I want to hear from you. Why do you think that patients with, or people with more prolonged clotting are the normal ones for this test? What do you think?
Because the protein C activity is not inhibited. It generally like it is an anticoagulant, right? Natural anticoagulant.
Correct, yes. So
it can inhibit the coagulation process.
exactly. Because in this assay, what I'm doing is that I activate a protein C, okay? Then I will run something that is basically an APTT assay. So protein C will try to inhibit factors 5 and factors 8. So if this is a normal person, protein C will be able to inhibit factor 5 and 8, causing a prolongation in the clotting time. Okay, so this will mean that the patient with more than 120 seconds, because this cutoff was validated by the R&D, of course, using clinical studies. So people who, sorry, not clinical studies, it was validated by the R&D during the validation of the kit anyways. So the patient who is normal, where a protein C can inhibit factor 5 and 8, okay, because we're inhibiting factor 5 and 8, the clotting time will be more than 120 seconds. However, if someone has factor 5 Leiden, factor 5 resists inhibition by protein C. So the clotting time is reduced below 120 seconds. So if someone gives you a result of APCR below 120 seconds, then I would suspect them of having factor 5 Leiden. And generally, how do I confirm that? With genetic testing. I will test that this patient has this factor 5 Leiden mutation. Okay? So this cutoff will differ from manufacturer to manufacturer. Some of them, they report ratio. It depends. For Stagos case, the cutoff is 120 seconds. More than that, you are normal. Now, we are done with the testing, with the normal stuff. Now, some stuff that the lab should be careful with these assays, because thrombophilia testing generally is sensitive. Protein C and S clotting assays tend to be very sensitive, regardless of the manufacturer, okay? And generally, protein C and S clotting assays, I'm talking about clotting, not chromogenic, they tend to have very short onboard stability. And the reason mostly has to do with that part of the assay is a protein C deficient plasma or a protein S deficient plasma, okay? And usually deficient plasmas have very short stabilities. The other point is that preparation of these reagents, at least in Stagos case, the preparation of this reagent is very, very important to be followed exactly as Stagos says in the IFU. So for protein S and C, for example, the stabilization time is 1 hour. If you do stabilization time half an hour or 45 minutes, your results are likely to be very bad. Okay. The incubation also is very, very important in these assays, the clotting protein C and S. Even a few seconds of difference in the incubation of a sample can cause the results to be bad. So these assays are very sensitive. Ideally, we run them by themselves. So when you have a batch of protein C and S, you stop everything, you just run these, ideally. Some labs, they cannot do that because they're very busy, they don't have a backup instrument, all of that. But ideally, you would run them by themselves, a batch on their own. You don't run with them protein or anything else. And this is ideally done after you maintain the analyzer, make sure it's clean, because again, these are very, very sensitive assays. Okay. Now, for factor assays, okay, now this is general, by the way, this is general points. What should the lab be careful with? All right. For factor assays, it is preferable to start with the fresh reagents. So, for example, I have a calcium chloride on board the analyzer that is 2 days old. Okay, it's still stable, but factor assays are sensitive. Less sensitive than protein C and S, but it's still sensitive. By the way, for protein C and S, having fresh reagents is not a question, it's a must. Has to be everything fresh. So for factors, you should ideally start with everything fresh, ideally, to make sure everything is fine, because if your calibrator fails, you would have to repeat everything. So you have just wasted your reagents, and then you have to start with the fresh reagents again. So just start with everything fresh, reduce the headache for yourself. And it's somewhat common that we see if you use old orange color or old calcium chloride that your calibration or QCs for factors would fail. All right. So these generally are precautions that mostly need to be followed with the protein C, protein S, or factors. They're generally the ones that we see to be more sensitive. Okay. Other points will be von Willebrand RCO, but you would not be running that, or factor 13. I don't think you would be running that as well. And pretty much that is the end of the presentation. And we are on time. Very good. So does anyone have a question? Does anyone have a comment? Do you want to discuss any point? You are more than welcome.
Okay, no more questions. If we have any questions, we will contact you through Ibrahim, and I think that will be.
You are more than welcome. Whatever you need, I am ready to help. Me and Ibrahim are brothers, so you guys are always welcome. So I will stop the recording then, and I will stop sharing.
Okay, thank you so
Okay.
much.
Thank
You
you
are very,
guys.
very much welcome. I am very happy to be of help.